We are moving to English session. Today is our 1402nd day of continuous webinar. We are conducting this without any break. Thank you all the participants for joining with us. And now it is the time for the prayer. Let's start our meeting with a silent. Good evening and welcome once again. Today we got a great personality to take class for us because Dr.NAVIN PAWASKAR. He is MD in homeopathy, MICR from Bombay, MHA from USA, CPDM from USA, and member of many committees. I think the profile of him is very huge. Even though I will mention here, member of expert committee of National Council for Homeopathy, member of CCRH. Central Ethics Committee, Healthcare Consultant, Director of JIMS Healthcare, Director of Parimal Project Private Limited, Director of Validus Healthcare Private Limited, Arif Integrative Healthcare, Founder Director of Primary Healthcare Foundation. He has a lot of experience. 10-year experience in disaster and emergency management, 20-year experience in administrative expertise. He worked as 28 years of experience in hospital-based clinical experience, 16 years of experience in teaching, and 18 years of experience in research, and member of many organizations. And he's an author, and he got many awards even from California, USA. And I'm inviting Dr. Navin to our platform. We are so glad to get you as a speaker today. Thank you.
Thank you. Am I audible?
Yes, sir. Yes.
So, Doctor, thank you very much for that introduction. I'm going to talk today, and at the outset, I would like to thank Dr. Sani and all the organizers who have done this tremendous job of going through 1,000+ lectures. So I really have no words to praise you, as well as I would like to thank you completely for this wonderful effort. Thank you for inviting me here, and I am going to present a study that is my screen visible, sir?
No, noted. You start to share.
Share screen.
Okay, share.
Is my screen visible?
Yes, application of homeopathy in clinical dentistry.
That's right. So let me tell you a short story about what this is. So this is a study that we did long back on around 800 patients, 700 odd patients, who were studied together by me and one of a qualified dentist who worked together on this particular project to understand how homeopathy can be used in clinical dentistry. So this is a study done by a dentist as well as a homeopathic doctor. That is so that's the interesting part of this. Yes. So I'm just purely sharing this study with a very pure academic interest. There's no commercial interest involved in it. And that's what I would like to say over here. So this is the number of patients that we studied in this particular. So 843 patients, out of which 565 were treated only with homeopathic medicines. Patients who got relieved were 394, that's around 70%. Number of patients who did not get relief with homeopathy were around 43, that's around 8%. And we lost to follow-up, means those people whom we could not completely keep a follow-up to say which category they fall into were around 22%. Only around 2% patients had to be shifted from homeopathy to allopathy because they didn't get adequate results. So that's how it is. So 67% we could treat and 33% with integrative care, where the dental surgeon was involved in the treatment. So what was our method of study? Clinical history and examination was conducted, dental examination was conducted by the dentist. A diagnosis was arrived at. We would create a homeopathic treatment plan for them. A patient was asked to give a consent for homeopathic treatment. And we would use a certain clinical record, which was a mix of dental record and the homeopathic record, which was specifically designed. At a given point of time, we would use only one single indicated homeopathic medicine in each patient. And we judged the clinical outcomes were judged by the dentist, not by a homeopath. So homeopathic doctor was treating and the dentist was supervising and judging the outcomes compared to what he would see in his regular practice. So if you can see this, these are the 13 different clinical conditions that we treated, right from pain and infection control in caries, post-extraction pain and hemostasis management, root canal treatment, periapical abscesses, periodontitis, polyps, dental sinuses, impacted tooth, periodontal abscess, alveolar abscess, bleeding gums, denture soreness, and prophylaxis before RCT and extraction. So you can see this 13 different clinical conditions were treated with homeopathy, and you can see on the right side the kind of percentage at which we were treating this particular clinical conditions with homeopathy. What was the overall outcome? You can see 70% patients had complete relief with homeopathy. 22% we lost to the follow-up. That means I do not have a very clear idea of what happened to them because they were not completely followed up by with our team. And there were 8% patients who did not get relief with homeopathy. So this is the overall outcome of these 500 cases that we are talking about at this point of time. If you would like to understand what were the more common conditions, that's what it is. Caries for pain and infection control was the most common thing. Post-extraction control for pain and hemostasis, that is bleeding, and root canal treatments were the most common thing, including a periapical abscess. So these are the common conditions that we treated, and you can see the percentage of them over there. Most common homeopathic remedies which were indicated, only one at a time. You can see arnica, Merxol, Staphysagraria, Plantago, Hypericum, Hiparsulf, Eclalava, Merck IF. These are the most common indicated remedies that got indicated in this particular study, and this is the percentage at which they got indicated. So 31 different homeopathic remedies were used in this particular studies of 569 cases. As you can see, more commonly used remedies were arnica, Merxol, Staphysagraria, Plantago, Hypericum, Hiparsulf, Hecla lava, Merck IF, to some extent Coffea cruda and silica. Now, what was more important is to understand which ones worked efficaciously. So 93% of the time that we prescribed arnica on indication, it worked. The same is true for Merxol, which is around 83%. So if we prescribed in 100 cases on indications of Merxol, 83 times Merxol would work. The same with Staphysagraria, 78%, Plantago, 85%, Hypericum, every case of Hypericum that we prescribed on clinical indications of Hypericum gave results. If you see, Coffea was our poorest, outcome remedy. It was only working around 25%. So if we prescribed 4 Coffea cases, only one would give some sort of a relief. Now, why this is important is because we would like to understand when we say that we are prescribing a single remedy based on the characteristic and clinical indications of that remedy, how true are those indications is always, known by how efficaciously they worked in that particular clinical condition or in that particular case. So, we get more confident when we know that these indications are true indications, and that if you prescribe the remedy based on these indications, there is a possibility, high possibility, that your patient will improve. So that is why this, efficacy of a remedy becomes very, very important. And these are not some things that we have done on empirical basis. This is based on the statistics that we arrived from the type of remedies and the indications that were used to prescribe that particular remedy. So you can see remedies pre and post RCT for pain and infection control. Most of the time it is Staph aureus, hypericum, and arnica, and sometimes Hecla lava. And I will discuss short cases which will help us understand why these remedies were indicated. And the same post extraction for hemostasis, pain control, pain and infection control, it's more common is arnica, Staph aureus, and plantago. And in some cases, Hecla lava. Hecla lava, I will specifically share a case where you can understand why these indications come up. Now, what was our method of study? How did we actually manage? How did we actually study the entire, program? So our job was very simple. We first would try to establish the cause of the distress. Why is the person having that particular pain or distress? Then general observations of person in general, observations of response of the persons to pain. What happens when a person is sitting on a dental chair? We would have a ice cold spray, we would have a warm spray, and we would have a lukewarm spray. We would also have a sweet spray, and we would spray them and ask them what are the different responses that they would feel. So that gave us the individualization to those particular modalities that we were looking at. Then we would look for any peculiar sensations that they were experiencing. And let me tell you, 95% of the people did not experience anything peculiar. Most of them would just be in severe pain or distress, and they were hardly able to describe any peculiar type of pain. But modalities, we objectively observed by using those sprays to understand what they were more sensitive to. More important was inspection of the tooth in particular. How was the appearance of the tooth? What is the seat? Where is the actual problem? Whether it is the dentine, whether it is the pulp, whether it is the enamel, whether it is the root, whether it is the bone, socket, ligaments, where exactly is the problem, that we would understand and use that as for tissue affinity and locations, and then help for prescription. And one more important thing was to observe the discharge and the odor coming from the mouth. So these were the individualizing features that we used. And then we connected all this to understand what is the totality and hence made a prescription. So this is the method that we used. First, establish the cause. Second, observe for generals in the patient. 3, objectively look for person's response to pain, any peculiar sensations, the inspection of the tooth in terms of appearance, seat, structure, how whether the crown is crumpled, whether it is black, whether it is brown, whether it is bleeding, oozing, all those things, and then the discharge and the odor from the mouth. And so this is how we individualized each case. You would probably understand that we did not ask patients a lot of history. We were more focused on objective symptoms to understand the totality of characteristic totality. Now, to really understand dentistry, I think I would quickly revise some of the basics that we have to understand. A tooth bud, there's an embryological aspect that we need to understand. First, a tooth bud evolves from two things. One is the ectoderm and another is the mesenchyme. Now, I know that embryology is a bit of a complicated subject, but for us to put it in a very simple term, which we understand from a homeopathic perspective as well, enamel is something which is evolving from ectoderm, so it is meant to protect. And mesenchyme is something which is, the dentine and the pulp emerges from a mesenchyme, so it is meant to nourish and sense. Right? Now, why this is important? Our skin is formed out of ectoderm. So it's essentially a protective organ. The same is with enamel. Our nerves are formed out of the deep other tissues, which is essentially tissues which are supposed to nourish and sense. So why this is important for a homeopath to understand, I will take it to the next slide. So enamel is a protective tissue, while dentin plus pulp is a vital tissue. So enamel is dependent on dentin and pulp to supply oxygen and nutrition. It's the other way around. The outer tissue is dependent on the inner tissue because the dentin and the pulp lies within the teeth to supply the nutrition and this thing. So enamel is hard and insensitive. It doesn't have nerves. So it is hard and insensitive, whereas dentin and pulp is highly sensitive. Enamel has no nerves. Dentin and pulps have tubules of blood vessels and nerves. How does it clinically make sense? So when you get a caries, by the time it only gives you sensation and pain only when it has eroded the entire enamel and it has started to touch the dentin. So you see, by the time a patient comes to you, there's already destruction. And that destruction most of the time is irreversible because there is no way that body can rebuild the enamel. There's no natural mechanism to rebuild that particular enamel. So the clinical aspect of this is because the enamel is dependent on dentin for reporting a pain, most of the time, unless the entire enamel is destroyed, the patient does not report pain. So most of the caries, if you see from a homeopathic philosophy, come with a destroyed tissue. And they are progressive. And most of the time, the destroyed tissue there is no mechanism in the body to revert that tissue back. So it is destroyed forever. And that is why it's important to understand the quality of the tooth that comes, which helps us individualize a patient. So there is familial predisposition and influences that impact the quality of ectoderm because we inherit our ectoderms from our genes, from our familial predispositions. So you see, this makes complete sense as to what is the stage of disease, what is the type of pathology that is going to be there. When does a patient report pain? The patient reports pain when the tooth is almost 50 to 60% destroyed. And that is when he comes to dentist or comes for a treatment. So when people say, does homeopathy help caries? Well, we have to understand at what stage they come to you, and that is where we decide whether homeopathy can help in caries restoration. But homeopathy definitely helps in caries pain management and caries infection management. Now, most of the dental diseases are chronic progressive diseases from a Hahnemannian classification point of view. They are chronic progressive irreversible structural diseases. And very often a patient reports to you when there is an acute exacerbation of one of those chronic diseases. And mind you, most of the patients who come to present with the tooth pain would only present to you with a singular symptom saying, I have toothache. There's no other symptom. There's one single pathology and one single pain that they talk about. So most of the time, they present with a one-sided presentation. So this is the overall understanding of dental diseases from a homeopathic perspective. Your predisposition, that is your genes, and your race and the familial predisposition reflects in your anatomy of the teeth and the nutrition of the teeth. And then how you conduct yourself in terms of keeping your oral hygiene, keeping your diet, these become your maintaining factors. And then finally, the disease evolves because of the combination of the constitutional tendencies and the maintaining factor and what you have inherited from your family in terms of quality of tooth that you have. So you can understand that we have to take into consideration all the three factors, and the entire philosophy of homeopathy of predisposition, constitution, and maintaining factors can be applied in this particular scenario and used. So this is what I think I described this. This is what we were doing as a method when we were trying to understand how to prescribe a homeopathic medicine. So there are three types of caries essentially. The first one is enamel carie, which is just a rough surface and it is asymptomatic. Mostly patients will come when there is food lodgement. That's it. And these don't have any. This is the time when you can do conservative restoration. These are the caries which will show a chalky spot or a block, just a small bluish black spot on the teeth. This is the time when you can restore them back. Okay. Then there is dentine caries, which are very deep. They have a black or a dark black appearance. They are spreading very fast and they are the cause of food lodgement. And this is the time when patient starts experiencing sensitivity to cold, sweet, hot, and sour. And these pains are usually, the common pains are lancinating. So this is the time we can enter either through surgical management or root canal treatment or extraction. And the last one is the dentine caries, which are deepest, where the crown has crumpled and the pulp is open. And this is the time when bacteria invades the teeth. And a patient comes with what we call as pulpitis or abscesses. So there are two types. Pulp, when it's exposed, there is reversible pulpitis and irreversible pulpitis, both acute and chronic. And in this cases, you will see that there are some where there was gangrenous pulp, there was necrose pulp, and there were periapical abscesses as well. So once again, I'm trying to show you this particular picture where you can see how a caries progresses from a simple, enamel caries to dentine and then the pulp caries. Now, how do you understand the peculiarness in a case? That is where we are trying to talk about this. So this patient presented with a dental caries, which was deep enough to as a pulp caries as well. And the patient had, as I said, we observed only two things. One, there was chronic but very putrefied and offensive discharge coming out of that tooth and the mouth. And the second thing that we observed was, although there was complete necrosis of the pulp, it was completely painless, which is unlikely, which is highly characteristic because a tooth which has a dentine pulpitis is supposed to be extremely painful. Whereas this particular patient, in spite of the fact that there was necrosis of the pulp and there was a putrefied offensive discharge, was completely painless, and hence he reported so late. So the RCT was done, but in spite of that, this pus was oozing, and that is where we came into picture and we prescribed Lachesis 30. Now, why should we prescribe Lachesis? Because Lachesis has action on nerves and the blood of the teeth as well as the sensitive tissue, and it has both the aspects. It is hypersensitive as well as it can present with complete anesthesia. And of course, we know everything about the Lachesis discharges. There will be excessive painfulness or there is complete anesthesia. And we know the Lachesis discharges which are acrid, which are extremely offensive and putrefied. And most important thing, Lachesis is useful after we had punctured injuries or injuries with sharp instruments. So necrosis after punctured wounds or gangrenes and necrosis after the injury, I think everybody knows Lachesis is the remedy that comes up. So what I'm trying to say here is, by just looking at the teeth, not asking any symptom to the patient, understanding what is the pathology and the sphere of action of the remedy, with one single modality, we could prescribe Lachesis. Now let's look at periapical abscess, which is second complication of dental caries. Now in this particular case, you can see that it is gradually developing. Pain is radiating type and it is better by warm, and more important, the swelling is limited to the gums. The abscess is limited around the root of the teeth and in the gums. And the characteristic here was thick white coated tongue posterior. And important thing was there was erosion of the first 1/3 of the teeth with brownish discoloration. The crowns crumple with coating of the tongue and infection settling in the gums. It's usually Merksol. So you can understand now how we could differentiate lachesis from Merksol. Once again, we hardly asked any symptoms. You can see there's no classic homeopathic history that we are talking about. We are making totality out of understanding the observational symptoms and pathology. Now here, if you see, again, the crown is destroyed. There is what we call as hard inflammation of acute inflammation of the pulp, and tongue is moist, pain worst at night, and aggravation by both hot and cold. So this was again one more Merksol that I'm just giving sample understanding to understand how we were trying to prescribe in this particular cases. Merck IF, I think the symptomatology and presentation is very similar to Merksol, except the fact that you will usually see right side and right upper teeth getting involved. Now I'm talking about even the location of teeth. If you can see, I have written right upper 6th tooth, or LL6, that means left lower 7th tooth. So even the quadrants of the teeth, there are 4 quadrants for the teeth: left upper, right upper, left lower, and right lower. Even they help us understand what are the different remedies that would come up. So if it is Merck IF, mostly it will be right upper teeth, right side and upper part of the teeth, and the presentation is very similar to the Merksol. Now here, if you see, what we did was, this patient had caries of teeth in the left lower 7th teeth with sharp pain radiating upwards. So radiating pain is one thing, and most important thing was that there was extra oral swelling. The swelling had actually come out beyond the gums into the oral cavity, and the pain was so much that patient was not even able to open the mouth. So much was the spread of infection in the oral cavity. So that is why in this particular case, we first prescribed Merksol, which did not give lot of relief. It gave only some relief, and the case stopped improving. This is where we introduced one single dose of an anti-miasmatic remedy called tuberculinum bovinum, and then again followed it up after 48 hours with Merksol 200 4-hour. So you see, when the infection is extra oral, that means it has started spreading beyond the realms of the teeth and gums into the buccal cavity. And when the response comes for a first few days and stops, that's where we introduced the anti-miasmatic remedy and then followed it up with the indicated remedy. Now, why Merksol becomes so much important? But if you see, it has predominant action on gums. It acts on fibrous tissues. It acts on periosteum. It acts on dentine and the crown. All the anatomical structures, Merksol has an action. And more important, it also acts on the glands, the submandibular glands, which is where the infection essentially gets caught. And you can see even the pathology, it has all kinds of, it has exudations, abscesses, necrotic pus, and even gangrene. So you see, Merksol is all about destruction. And of course, you can all understand that Merksol has both the extremes of modalities: worst by heat, worst by cold, and most important, worst by night. So you see, Merksol is actually, why it becomes important is because it has the entire gamut of symptomatology and clinical indications that an oral cavity disease can present. That's why Merksol is an important remedy. I showed you how, I kind of discussed what are the indications that you need to pick up to prescribe Merksol. The same with Merck IF, except that the patient is hot and there are extreme modalities: worst by heat and better by cold. Merksol is worst by heat and cold, whereas Merck IF is worst by heat and better by cold. Both of them have night aggravations, but More important is, one is hot patient, worst by heat, better by cold, and right-sided presentation, mostly right upper teeth. This is where Merck IF comes into picture. Now, how do you differentiate? Now, the next thing about the dental caries is, the next complication is periapical abscess. Hiparsulf gets indicated in a very, very simple thing. You will understand that unlike Merck IF and Merck Sol, they are extremely chilly. That's one. More important, when you look into the oral cavity, you will see an literally fluctuant abscess. In Merck Sol, you will see gum induration. The abscess is lying underneath that indurated gum. Whereas in Hiparsulf, if you look at the oral cavity and the teeth, more than the dental destruction of the crown, within the inside the gums, you will see fluctuant abscess, extreme chilliness, and hardly able to move the mouth. So fluctuation, where the crown is preserved, unlike Merck Sol where the crown gets destroyed. Here the crown is preserved, but the infection is at the root, and the abscess you can see next to, popping out in the gum, and which is fluctuant. It is not indurated. It is almost as if it is going to burst now. And patient has fever and chilliness at that point of time. This is exactly where Hiparsulf comes into picture. Once again, if you see, we're not talking about a lot of subjective symptoms. We're just looking at the feel of the abscess, the look of the abscess, and how the stage of the abscess that it is in. It is fluctuating. It is almost as if it will burst now. Same story with Hiparsulf here also, fluctuating and pointing abscesses. Please, this is an indication of Hiparsulf. Abscess which is fluctuating. It is almost like I'm going to come out now. And of course, better by warm drinks is a characteristic of Hipar. So we would use these sprays. You see, there was an ice cold spray, and there was a warm spray, and there was a sweet spray, and then there was a sour spray. And we would just put it over there, and patients would tell us, this is what is paining me more. So, I mean, I think I've described Hiparsulf over here. More important, it is more extremely oversensitive to pain, and there will be an abscess or a fistula in the dental thing that it will come out. And predominantly does not affect the crown. It's prominently about the gums and the periapical region that we are talking about. Now, how do we understand silica from the Hiparsulf? More common, it is a hard abscess. Hard abscess, which is it is either drained, open up, or it is not, it is opened up, but that opening is not healing now, and it is chronically or over 7 or 8 days pushing out the discharges. Another indication is the left-sidedness of it. So there is clinical state of sinus in the teeth after the abscess has naturally drained. So this is where silica comes into picture. So in this particular case, there was an extraoral abscess with a drained sinus which had naturally burst open, but the sinus and the abscess was refusing to heal. That is where we prescribed silica 30. So you can understand the speed of Hiparsulf is acute, sensitive, and chilly. And it is almost, I'm going to burst now. Whereas silica is slow, chronic, already burst, but refusing to heal. So that's what silica looks like. Slow and incomplete process. Slow and incomplete process with lot of induration, festering and decaying, and stubbornness. Silica is extremely stubborn. It does not move. I will not heal, it says. Do what you want to do, but I am not going to heal. That's silica. Hiparsulf is, oh my God, I am very sensitive. Don't come near me or I will become violent. You touch me and I will burst. Whereas silica is, you do what you want to do. I am sitting here. I will keep pushing out the discharge every day. I will be hard. I will be slow, and I will be stubborn. I will not move out of this place. That's silica. This is how silica abscess is all about. So, I think you have understood by now that we were essentially using what is called as bogus approach. We looked at the concept of time and evolution and the stage of disease. Rapid paced remedies against slow paced remedies. Hipersulf, rapid paced. Silica, slow paced. Merxol, somewhere intermediate. Stage of the disease, whether it is an indurated abscess or whether it is a discharging abscess or whether it is a fluctuant abscess. Then certain modalities that we are checking, tissue affinity. In Merxol, it's usually the hard tissue, the chronic, the crown of the thing. Whereas in Hipar, it's usually the soft tissue and the pulp and the root of the teeth. Whereas in silica, it's soft tissue and the teeth, but hard, indurated, and discharging. And then we looked at the sensation. And if you can understand, the subjectivity of sensation was the least that we paid attention to. Now, where do you use, left lower teeth with submandibular gland enlargement and tenderness. After extraction, the pus keeps coming out. So this is a deeper pus. This is coming out of what we call as the socket of the teeth. That means which is socket of the teeth is essentially the bone. So this is where, when you see that the pus is coming out of the socket of the teeth in a hot patient with a chronic sinus out over there, that is the time to think about fluoric acid. That is the time to think about fluoric acid. And in this particular case, we used fluoric acid, which has rapid decay, fistulae dentalis, fistula in the gums, and violent pain with frequent discharge of pus. So you can see caries, necrosis, fistulas, sinuses, which are bone deep, right? Which are bone deep. That is the depth of fluoric acid against when we look at Hiparsulf. And slow onset of symptoms. Creosote, similar depth, but will have lot of acrid and offensive discharge. Similar to fluoric acid, but will have lot of acrid and offensive discharges. And that offensivity will be, you can smell it the moment he opens the mouth. That is where creosote comes into picture. And mesothelium is very similar to Hiparsulf in terms of its sensitivity, but extremely radiating prosopalgic pain. That means radiating neuralgic pains from the teeth. So when you see predominantly nerves getting involved, that's where mesothelium comes into picture. Less of infection, but more of nerves that get involved, and excessive sensitivity to, even the patient will say that even if I suck air inside, I feel extreme pain. So when you push that air cannula onto him and press the button, he will just jump out of the chair. That's mesothelium. Right. So this is the way that we can differentiate the remedies. Really not without asking too many symptoms, but just by observing the stage of the disease, type of tooth that is there, some basic modalities, and you are able to understand which is the remedy that comes up. Now in root canal therapy, this is the second common clinical condition that we handled. Most commonly for caries, pulpitis, periapical abscess, and prophylaxis. These are the time when we use. Now, when do we use? When people get post-surgical neuralgias in root canal. Sharp radiating pain from tooth to face and ear, aggravation by slightest touch, and which is not continuous, which comes and goes intermittently. Where the crown is preserved, that's where staph aureus comes in. Intermittent, post-procedural, that means post surgery, radiating, and touchy. Staph aureus is touchy. You touch it and the pain comes. That is staph aureus. right? It has sudden, rapid and violent effects, and it is essentially used when, if you can see, the action of Staphylococcus aureus is on alveolar, periosteum and nerves, teeth nerves. So when you touch it, when you do a root canal, the alveolar is touched, and that is where the pain emerges from there. And if you can see, the teeth decay very fast and the tooth is brittle. So when you do a root canal, you will see that the crown crumples. And a lot of dentists will complain that the crown crumples when I'm doing a root canal, and the patient is extremely sensitive. That is where Staphylococcus aureus is indicated, as you saw in the previous case. Hypericum was the most important remedy when it came to post-root canal neuralgia or neuritis. Injury by sharp pointed instrument and penetrating wound, commonly used when the pain is intolerable, lancinating along very pain and extreme worst in the night. Unlike Staphylococcus aureus, which is worst by touching, hypericum says I want to rub it. So it is same as Staphylococcus aureus because they are sudden and violent. They affect the nerves, but more important, Staphylococcus aureus has a brittle teeth. Hypericum does not have it, and Staphylococcus aureus is extremely touchy. If you see the generals of Staphylococcus aureus, touchy patient, whereas Hypericum wants to touch, rub, and massage karna hai usko. That is how Hypericum is differentiated from Staphylococcus aureus. Coffea, I think this was my worst remedy. I failed a lot with coffea. I used to often prescribe because of its neuralgic action and convulsive, it was so much extremely painful remedy that you can't sit in place and the anguish of the patient. But I found that the indications of coffea on which we prescribe, that is holding the ice water in and cold water, did not really work out well. So I got very poor responses with coffea. Like I got only 25% success with coffea. Other than, I mean, if we look at Staphylococcus aureus, it was almost around 85%. Hypericum was almost around 100%, but coffea was very poor when I used it for post RCT neuralgias. Plantago is extremely useful for this as well. Okay. More important, like Plantago has a symptom like Merksol. It has flowing saliva. It has flowing saliva like Merksol. It is not dry. It has flowing saliva like Merksol. And more important, there is a peculiar location. Pain centers between tooth and the ear, not inside the ear, between the tooth and the ear. You can literally draw a line between the tooth and the ear, and the patient will tell you exactly in middle that this is where my pain is. Right? So profuse saliva, coated tongue like Merksol, and radiating pain like Merksol, but the pain will be at a specific location between ear and the tooth. And this is where you will understand Plantago. Then we come to the last part. How do you manage post-extraction of tooth? Arnica usually for mechanical injuries because of extraction of tooth. When we extract a tooth, essentially what we are doing is there are two ligaments to the tooth, and both the ligaments are crossed. They are like cruciate ligaments. So when we mechanically, the tooth is moved, we are actually breaking those ligaments. Right? And very small part of the bone is actually affected. So basically what we are looking at is breaking of ligaments and nerves and blood vessels. And that's where the bleeding comes into picture for that. And that is the reason why we should use arnica. And why would you not use hamamelis? Because hamamelis also bleeds. But hamamelis does not bleed because the ligaments and the soft tissue is broken. Right? That is the difference between using arnica and hamamelis. When do you use Hecla lever? Right? In extraction of teeth. When we see that dental caries and root has reached a level where you have not only this is something called hard extractions, where you have also chipped off a bone. During extraction, when you look at the teeth, and you will see a chip of bone coming out, sticking to the teeth. And then the pain starts, neuralgic pain comes up. So you see, everything is not arnica. After every tooth extraction, you can't give arnica. You have to see the tooth that has come out. And if you see a bone chipping out with it, with a severe neuralgic pain, that's when Hecla lava comes into picture. Or the second situation when Hecla lava comes into picture is when the abscess has reached the bone and there is osteomyelitis. These are two conditions in the dental situation where Hecla lava will come into picture. When you are during extraction, if the bone alveolar tissue has chipped off, then and the patient has got severe pain, that's when Hecla lava comes into picture. So neuralgia after chipping of the bone along with extraction, that's where Hecla lava comes, or there is osteomyelitis deep inside the bone. So I think by now it is very clear that we have used these concepts to individualize the patient and prescribed one single remedy at one point of time. We have used anti-miasmatic remedy like tuberculinum, if you can recall. We have used causation to understand which remedy to prescribe. We have used tissue affinities to understand the remedies, like the crown affected, or the nerves are affected, or the gums are predominantly affected, or the ligament of the teeth is affected. Then we have looked at what we call as the modalities. So this is how we individualize these patients. I would like to say that the prescriptions were made by the time the dentist would diagnose. We were ready with our prescriptions because we were not actually asking them homeopathic symptoms. We were predominantly observing what was happening to them while they were sitting in the chair and deriving characteristics from them. So I think why Boger becomes important, because it helps you individualize in this particular aspect where you got to understand the pathogenesis, tissue affinity, and discharges very well. And that is why I focused on ectoderm and endoderm. That is why I focused on how the caries evolve and how the enamel, which is the protective structure, gets destroyed more than 50% before the pulpitis starts, and the nerves and the nutrition gets affected. And of course, the discharges, and lastly, the sensations. So we were differentiating remedy is essentially based on concept of time and evolution, rapidly evolving with the abscess, evolving with the necrosis, evolving with neuralgia, slow evolving, obstinate remedies, stubborn remedies, remedies which evolve fast but have no pain. So these are the concepts that we use to stitch together a totality. And that is why Boger's approach is what we used in all of these 500 odd cases. In my conclusion, I would say that this is a topic that should be taught. Sorry, let me just go back. I just hope I'm back. This is a topic that homeopathic medicines are very, very effective in managing routine dental conditions. Why they are important is homeopathic medicines are extremely, I think I don't have to talk about the cost effectiveness of homeopathic medicines or very minimal side effects, but it is important to work with a surgeon, a dental surgeon, to be able to deliver these kind of homeopathic cures, for them to understand that homeopathic medicines are highly effective and simple to prescribe, as well as quick to prescribe. I mean, can you imagine somebody being in a dental chair in pain and we are trying to take a long history out of him? It will be highly uncomfortable for the patient to give you that kind of a history, and hence he would not be cooperative. And there is a need to develop a standardized recording process, which is a combination of homeopathy and dentistry, where we actually record which tooth, which quadrant, what kind of a pathology, and what kind of a symptomatology based on that. So we need to really develop a record which will combine the concepts of dentistry and the concepts of homeopathy. Then we will be in a better position to use this. I think this is a very poorly taught topic in undergraduate. Usually out of 200 marks of surgery, dentistry is 5 marks. So it's like we give what can I say? We give 2.5% importance to dentistry in our study of surgery in homeopathy. We teach them, we give 2.5% of attention, which is very, very less. We have 200 marks of paper, and usually you will get around a 5-mark question or maybe around a 10-mark question max. So you are anywhere between 2.5 to 5% of your attention in the entire study is on dentistry. Whereas dentistry clinically could be highly paying type of cases for homeopathic doctors. Specifically, if you see in pediatric dentistry, there is very little that a dentist can offer, and that is where homeopathic doctors can give a better solution, and it could be a paying service to the patients. They could highly benefit because they can avoid using antibiotics and the deep painkillers. At the same time, we can give it to the children where they can consume it very easily and nicely. So I feel we should pay more attention to this particular topic, because there is a great potential for homeopathy to give relief in different dental conditions. In this study you saw, we used it for 13 to 14 different dental conditions, and I showed you the statistics and the kind of response that we could get. I am throwing this open now for any questions if there are. And once again, thank you very much for listening patiently. Thanks a lot.
Thank you so much, sir. It is crystal clear and evidence-based homeopathic explanation. It was great awareness for us, and as you said, we are not using even 2% also. If you have any question, you can ask. Dr. Danesh has already raised hand. Dr. Danesh, you can ask.
Yes, Dr. Navin Pawaskar's sir, it's really a very good session. Really, you give us how to enter into the field of dentistry with homeopathic medicines, and how one can differentiate all these medicines, and what are the important medicine, how one can utilize these things, and what are the why this bogus repertory is being used for this selection of this remedy, because the time and evolution of the symptoms is more important than anything else. That will change the medicine from one by one according to the situation. That's absolutely a brilliant session from sir. Sir, what is your opinion on frequent people used to take teeth extraction, total extraction, and thereafter they use dentures, and while using dentures, there will be frequent bite in the chews, in the gum and mouth also, even in tongue also. What is your precision for that, and how will you manage those cases, sir?
Right. So, sir, people, there are the reasons why they go for total extraction is because the teeth become unviable, in the sense that you have lost the teeth on your left, you have lost the teeth on the right, and the center teeth becomes unviable, and hence it is physiologically useless for them, because they are not able to actually do the physiological function of chewing over there. Now, ill-fitting dentures is one genuine condition that is existent, that you do get out all the teeth are out, and then you try and fit in a denture, which usually becomes ill-fitting. What happens because of that is the person who is using the denture starts avoiding it, because it causes him discomfort, first of all. And the second thing is, because he does not he avoids the use of the dentures, the jaw structure starts modifying itself. Right? So it is important that we should use, see, it is like you are using a prosthesis. So in my view, it is your body is trying to learn to adapt to this new prosthesis. So as homeopath, I feel and I have seen that if you use a constitutional remedy while the patient is adapting to this prosthesis, these issues of malalignment, these issues of chewing, these issues of having these bites and small ulcers because of this friction are reduced. And provide, if that is when the patient is asymptomatic and he's trying to adapt, what your constitutional remedy does is essentially tells your body where you need to adapt. That's point one. Point two is, if the patient is symptomatic, that means either he has an ulcer or he has an erosion or he has infection, then we need to treat it with the acute remedies or the indicated remedies that as we saw in this particular case. So that would be my way of giving solution to people who have already undergone total extractions and they are looking to adapt. Because the failure of using prosthesis, I mean the dentures, is very, very high. And that impacts the overall nutrition of that person. Because he's not able to chew, he starts using diet which is not necessarily extremely healthy. It is something that he just do, and that starts having an overall impact on the nutrition of that particular person.
Okay,
So
sir.
as we say, teeth is the entry. So unless you manage that well, your entire nutrition gets affected.
Sir, one more question. Sir, what's your opinion on using phytolacca tincture as in diluted form as a mouthwash?
Sir, I haven't used it, so I am not not in a position, because I don't have the experience nor the data to tell you what it is.
Okay, some people used to advise those things, and that's why I asked the question, sir.
I'm not an expert on that.
Calendula 30, what's whether you use or not? Calendula 30.
Yes. Calendula 30 we have used. If you can see that we have used Calendula 30, but that is when you really, most of the time, my thing was that once you extract, the socket takes around anywhere between 48 hours to I would say a week, say 2 to 5 days to plug in. That socket gets filled up with the tissue. If the socket is not getting filled up with the tissue and you need granulation, that is the time that arnica should be followed by calendula.
Okay, sir. Thank you very much, sir.
Thank you so much, sir. Thank you, Dr. Danesh. I think Ram Parvesh sir has raised hand, but now it is the time for the Malayalam session. I'm so sorry, sir. We are moving to Malayalam session. I know you are you want to say the appreciation. I am saying Dr. Ram Parvesh sir's appreciation together with IFPH. Thanks. Okay. Thank you on behalf of IFPH. Now we are moving to Malayalam session. Dr. Mariamma John.